They'll start populating the room, and I'm going to go do a little bit of housekeeping in Facebook. So let me do that, and then let me do this. Let me do that. And while I'm getting Facebook ready, enjoy this.
Hello, I'm Lisa Salberg, founder and CEO of the Hypertrophic Cardiomyopathy Association. I'm excited to announce an important milestone in helping raise awareness of HCM. For those who don't know, hypertrophic cardiomyopathy, or HCM, is a heart condition that affects people regardless of gender, ethnicity, age, or geographic location. It is also the most common genetically inherited heart disease, yet many people living with the disease don't even realize they have it. With HCM, the walls of the heart become thicker than they should be. This excessive thickening can cause the heart to become more stiff and leaves less room for blood to fill the heart. HCM can worsen over time, potentially causing serious complications. It can be a challenge for healthcare providers to diagnose because its symptoms can be so similar to other conditions, and some people may not have symptoms at all. These symptoms can include shortness of breath, tiredness, chest pain, rapid heartbeat, fatigue, and dizziness. There is a need to raise awareness of HCM. And this is why I'm excited to announce that in collaboration with Bristol Myers Squibb, February 23rd will be HCM Awareness Day. We'll use this as an opportunity to share stories from people within the HCM community, educate people on the most common symptoms of HCM and the impact of the disease, encourage those who think they may be experiencing symptoms to speak with their healthcare provider and ask if they should see a cardiologist, and to encourage better family screenings through improved annual exams. We look forward to sharing additional details about HCM and having you participate in HCM Awareness Day on February 23rd.
Good evening, everybody, and thank you for joining us here in the webinar. We have about 55 people joining us so far in the webinar. If you're watching us stream on Facebook, you're going to be able to view tonight's events, but you will not be able to ask questions. If you would like to ask questions and join the Zoom room, it's not too late. You can go on over to the HCMA website and click on register for tonight's event, and you'll get a link and you can come join us and you can ask any questions that you want during the event. So I am going to hand the night over to Dr. Ferhaan Ahmad, a dear friend for many, many years and in 2 different centers now, who is going to introduce his team, and then we're going to get our evening started. Ferhaan, welcome to the Bighearted Warrior Tour.
Great, it's a pleasure. Thanks so much, Lisa. It's great to see you and your team, and I imagine we have a nice audience. I guess a lot of our own patients and family members from here in Iowa City and Iowa in the Midwest, but also I suspect some folks from around the country and around the world. So it's really great to welcome you virtually to Iowa City. It's a beautiful, balmy evening in February here. It is, let's see, it's 35 degrees right now in the evening here in Iowa City. So it's beautiful. And I'm getting a poll for geography here. Interesting. All right. Well, we have assembled really a great team over the years as we've developed a program here in Iowa. And I kind of asked some of our star members of the team to join us today for the webinar. And they have really great expertise in specific areas that I think would be of interest to everyone in the HCM community. And we're not trying to give you a comprehensive overview of all HCM. We just selected a few topics that are sort of up and coming, or there's new things happening in those areas, and probably areas that you're kind of interested in learning a little bit more about. So with that, I will introduce our team. I'll ask everybody to come on their camera so I can, and then you can wave and say hello. So our first speaker today will be Mahi Ashwath, who is clinical associate professor here at the University of Iowa. She's also an imaging cardiologist and director of our cardiac MRI program. Say hello wherever you are, Mahi.
Hello, everybody.
Great. Then we've got Dr. Denice Hodgson-Zingman, who is a professor at the University of Iowa and also a clinical cardiac electrophysiologist, and she emphasized the cardiac part of electrophysiology. She's also the former section head for our section of cardiac electrophysiology. Say hi, Denice.
Hello, everybody. Nice to be here.
And then we have Dr. Sid Panaich, who is a clinical assistant professor. He is also an interventional and structural cardiologist, the medical director of our structural heart disease program. And I know Sid was having some issues with his iPad. Are you there, Sid?
He's here. He's on mute, but he's here.
Okay. All right. And then we have two, not one, but two fabulous genetic counselors, Maggie Freese and Gabe Kringlen. And I know they were on.
Yes,
Say hello, guys.
good evening.
And that's Maggie, not Gabe. And then you heard
Hi, pleasure to be
the
here.
other one's Gabe, if you couldn't figure that out. And then we've got Becky Gutmann, who is our nurse manager for the program.
Hello.
And finally, we have got Katie Hallmeyer, who is our fabulous nurse practitioner in the program, and she's a lecturer in our College of Nursing.
Hello, everybody. Welcome.
Great. So that's our team today.
And we will be hearing from each of them throughout the evening. I am joined by HCMA volunteer coordinator Julie Russo tonight, who is stepping in to help Amy with Bighearted Warrior Tour, but Julie always shows up at our Bighearted Warrior Tours. So those of you who wish to become volunteers with the HCMA can see Julie and know who you're talking to. So we'll be talking a little bit about that tonight. So I'm going to kick off tonight's talks, and I'm going to tell you about some exciting things that are going on. You saw the video at the head of this presentation regarding HCM Awareness Day. So big stuff coming up here. We're going to talk about that in just a second. Let me do my screen share. Everybody else is doing their screen share, so we've got all of that. So welcome everybody, whether you're in Zoom or on Facebook, or you're watching this live, or you're watching this after the event. So it is 7:14 p.m. on February 10th. We are live now. If you're watching this later, we can't answer your questions, so post them and we might get back to you later, or call the office. For those of you who are in the Zoom room, please take the poll so we can know who you are and where you're from and get an idea of what everybody's points of view are, so we make sure that we're speaking to your specific needs tonight. We are going to kind of go over a couple of different things tonight in my talk. Try to cut mine down to high level program stuff so we can tell you what's new and exciting. Just a review of tonight's agenda. We are going to be talking about a number of different topics, including imaging, electrophysiology, the ongoing and never-ending debate of alcohol septal ablation versus myectomy, or whichever way you want to put that. We have two genetic counselors tonight, so we're gonna geek out on genetics, which is one of my favorite things to do. And then we're gonna talk about new developments in HCM and obviously how you can get in contact with this particular center. We will have questions and answers at the conclusion of our faculty's contributions tonight. We will leave the question and answer open for a few moments, live on Facebook and recorded. And then at the very end of the evening, we will save about 10 minutes and we will stop recording to have anybody ask questions that they may not want to be recorded for posterity on the internet. So we'll give you a few minutes at the very end of the session for that. So that's kind of the structure of the Bighearted Warrior Tour, and we're off and running. So first I want to introduce everybody to a new concept of medical education for HCM. And this is not for patients, this is for your doctors. And if you are contacting us via a webinar, or your doctor is not affiliated with a center of excellence, or you want your doctors in your local community to learn more about HCM, we certainly encourage you to bring them to HCM Academy. We can drop you off a card that has a QR code on it that they can scan and gets them right into HCM Academy, or you can go through the HCMA website. What is HCM Academy? It's a really amazing tool that we spent last year building. It has 6 online CME courses, 5 online CME case studies, and those 5 online case studies are 5 amazing HCMA warriors who opted to share their story to help teach others. I'm sorry, that's the non-CME part of it as well. So those are patient perspectives and they're a little bit deeper. Your physicians will also have the opportunity to join in a live discussion group with one of our trained HCM Academy experts, and they can go through deeper questions. They can have conversations with HCM experts about HCM. So not only can they learn the basics on screening, genetics, management, sudden cardiac arrest risk assessment, but they actually will have an opportunity to speak to a thought leader. So it's an amazing program. It was really expensive to run. And back here is our faculty. It was myself, Marty Marin, Anjali Owens, and John Lynn Jeffries. And the content is amazing. And we do have to thank our sponsors for this particular project, Bristol Myers Squibb, Sanofi, and Cytokinetics. They provided the funding, and just so you know, people, they provide the funding and they step back and they let us present the content in the best way possible for the clinical understanding of HCM. So it was really a pleasure to work with them on this project, as well as our partners at PCM Scientific. So you can go to the HCMA website and you can look up from programs, HCM Academy. That'll guide you to a page. If you are a person who would like to refer your physician in, you can fill out their contact information and we can send them an invitation. If you're a provider, you can click there and you can just sign up. It's a great program and I encourage you all to share it with your healthcare providers. And why is it? Okay, so legislative activities. Big news coming out of the HCMA. We have a problem. The problem is only 15% of those potentially able to be diagnosed with HCM are currently in care for HCM, which means 85% of those who would benefit from management potentially are not in the care of anybody anybody who knows that they have HCM at this point. One of the ways we're going to attack this problem is to improve the well child examination. And that means we're going to ask the same questions we ask of student athletes, but in the well child exam, giving each family an opportunity to discuss with their personal healthcare providers their family history, their risks, and have the opportunity to get a cardiac evaluation if one is warranted. Additionally to just asking questions, the HCM Act, which stands for Healthy Cardiac Monitoring Act, will require the healthcare practitioners who are doing the well child exam to take online training courses to better understand the diseases that can be associated with sudden cardiac arrest in the young and cardiac disease in the young. So we hope that you will all take a few moments to wander on over to the HCMA website, to our advocacy page. And Julie, if you could drop that in the chat box, that would be really helpful for our viewers. And you can just go to one website and 3 clicks can save a life. 1 to the HCMA, 2 to our program called UJoin, and 3, you fill out your address. You can write a personal note to your state level legislator, and you can even attach a video asking them to take action. And you send that on off, and hopefully we will have the opportunity to draft legislation in each state and eventually get that to pass as a law. So it's simple advocacy. You can share your family story on why it's important for you and your family to know about HCM, but explain that you are one of the only 15% that are currently diagnosed with HCM, and we need to go find that other 85%. So you can just 3 clicks and you can help save a life. The big topic of the month and the day, HCM awareness, advocacy, and action. Ladies and gentlemen, it has been a bumpy and wild ride over the past couple of weeks here at the HCMA because we have some late breaking information that we're going to be announcing to you on February 23rd, which has kind of made this day kind of change. We should have the finalized agenda hopefully by tomorrow afternoon. So nothing like last minute planning, but hey, in the day of COVID, everything is live and kind of flows. So number 1, all month long, we're featuring HCM warriors on our social media feed. And we hope that you have seen some of them either on Instagram, Twitter, LinkedIn, or Facebook, where you can share these stories. Some of them are very inspiring and positive stories of managing HCM successfully. And sadly, some of them are of untimely deaths due to mismanaged or undiagnosed HCM. regardless of their stories, each one of our HCM warriors is an inspiration and a cautionary tale, and both and one or the other, depending upon the story. So we encourage you to share them and share your own story with your friends and family so that they start to see the faces of HCM and that they're really right around them and they're not this, we're real, we have issues, we need to be understood. I'm going to invite you all to sign up for another webinar. This one's going to be a long one, but you don't have to stay all day. We are going to have a full day of programming in a webinar and streaming on Facebook on February 23rd. We'll start our broadcast at about noon, a little bit before noon, and we are going to feature a number of HCM centers of excellence who will be coming in to give some shout outs to the HCMA and tell us a little bit about what's going on in their programs. They're going to be short 12-minute talks. And then we are going to feature a very special segment with Dr. Barry Marin. Barry, for those who do not know, is probably the most well-published clinician and researcher in the field of hypertrophic cardiomyopathy. And just this month, he published two new articles co-authored in the American College of Cardiology Journal, JACC. And these are really important documents. They are complementary to the guidelines and a little easier maybe to understand and follow. The guidelines it's a heavy document. So Barry and colleagues have taken the opportunity to write this up a little bit differently, a little bit more practical approach for some. And I think the patients will find this incredibly interesting and informing. So please do join us for a special segment with Barry, and that'll be at 3:00 in the afternoon on February 23rd. We will be featuring patient stories throughout the day. We're going to give you some legislative updates. And at 7 p.m., I have a special announcement that I can't tell you right now, but it is big news in the HCM community, bigger for some, less so for others, depending upon where you live and where you get your care. But there's going to be some shifts, and I will have all of the information on what you need to know about it on February 23rd. So you'll want to tune in for 7 p.m. You'll really want to tune in for 7 p.m. I can't say more. So I'm going to move that slide now. So we're happy to say that our HCMA Recognized Center of Excellence program continues to grow. We should be getting some new programs onboarded by the end of the year. COVID kind of knocked us for a loop on our stride to getting new programs in the system. As of right now, there are 43 HCMA Recognized Centers of Excellence in the United States. We are working on our first international program. You've heard me say that a few times now, but Canada will be coming online with us, and then we're going to be going to Europe with some programs there. But the US still needs another 20 or 30 so programs at the end of the day. Not all will be equal. Some will be comprehensive programs that take care of peds through transplant, and some will be good management strategies where you might have to go elsewhere for surgery or transplant or peds, but we're going to be building strong models throughout the country. So we have nothing really coming up for publication probably before June, but by June we should have a couple more programs. But if you do not see a center in your neighborhood, my pending programs are not quite well populated on this map. My apologies. You can call the office and say, here's where I live. Is there anything coming up in my region where we may have a physician who is interested in HCM, but hasn't quite built the center up as well as needs to be approved by us. So you can call us and ask. If you're watching on social media, you know where to find us. If you're watching in webinar, these are the groups that are attached to the HCMA. So we have our international programs out of Sweden and the Netherlands, and we have our patient discussion group and our parent discussion group that are tied to our HCMA Facebook group. There will be some additional programs coming in from the international front where we will help people communicate in their native language about HCM as we move towards better health equity throughout the globe. So stay tuned for more programs there. If you have not signed up for an HCMA discussion group yet, I encourage you to do so. Our peer moderators and leaders hold fantastic sessions and have really inspired a lot of people to get more involved in the HCMA, get more involved in their own healthcare, and know that they're not alone in their journey. So we have these programs, there's at least 1 or 2 a week, every week. So if you feel alone, you're not sure where to go, you have a discussion group to join, and you'll find some wonderful friends and some information. Hopefully we'll get back to some in-person meetings in the next several months, hopefully. But for right now, your Zoom room and your couch are all you really need. The Tales from the Heart podcast continues. We're in now season 2. And thankfully, we have some amazing participants coming up. Marty Marin joins me once a month. Harry Lever and Steve Onman flip-flop on months. And we have special guests monthly. So take a look at our calendar of events and look at our Facebook group, because we do stream our podcast live and you can ask questions during the podcasting. Typically, it runs at 11 a.m. Eastern time on Fridays, which means I will be back in this office tomorrow morning and we will be live podcasting with Marty Marin tomorrow. If you have not already done so, if you're interested in genetic testing, you're going to hear about genetics tonight. I would strongly encourage you to look at the Invitae program called Detect. It provides no-cost genetic testing to HCM patients and their families. And we are really happy that Invitae is continuing this program. It is provided through industry support, and there are no strings attached for the patients. But if you want to have more information on that, please take a look at the Detect program and speak to a genetic counselor. So it's Heart Month, and I don't stop every Bighearted Warrior tour and acknowledge why we do what we do here at the HCMA. But this lovely lady is my sister Lori. She passed away in 1995 from mismanaged hypertrophic cardiomyopathy. And it is because of Lori and what our family had to endure at the time of her death that we are here to provide others with the support, education, quality care, and advocacy efforts that are needed to ensure that you all can live long, happy lives with HCM. So as we are in Heart Month, it would be not right if I didn't bring up my big sister. And Lori became an organ donor. So she gave her kidneys and her liver. So I do also encourage you to remember to sign your organ donation card or the back of your license. Always an important thing to do. So this Heart Month, I give cheers to my sister. We want to thank our partners at the University of Iowa, all of our Center of Excellence partners around the country and the world, our amazing staff at the HCMA, our board, our volunteers, and of course, my donor, Brandy, and her family, for without whom I would not be able to be with you tonight. So I'm going to stop my screen share here, and we're going to go back to my PowerPoint on my other screen. And I'm going, whoops, where did I go? I lost you all here for a minute. Here we go. Oh, I hate when that happens. There you are. I lost you for a minute. You're back now. And here we go. So who is up next to bat? We have to pull up the agenda, and we are going to jump right into imaging and how imaging is superior at an HCMA recognized Center of Excellence. Mahi, you are up to bat. So why don't you unmute yourself, share your screen, and I'm going to close the poll out, I think. Let's see where the poll looks like. Oh, it's over here. Okay, I'm going to leave the poll open a little longer. For those of you who are participating, take the poll. Just let us know where you're coming from. As of right now, we're all US based. And at the end of this talk, I will tell you all who else is in the room with you. So please take the poll. And Mahi, off to you.
Thank you very much, Lisa. That was an amazing introduction to your website, to everything you've done, and the tribute to your sister. I think that's amazing. And welcome to the imaging portion of this talk, and welcome to Heart Month. So I'm going to just kind of touch briefly about the different imaging modalities and a little bit about what we can do here at the University of Iowa. I'm going to talk about a little bit about echocardiogram or ultrasound of the heart and stress echo, and then a little bit about cardiac MRI and cardiac CT. So how are these patients usually recognized? As many of you know, most of the times it starts with some non-specific symptoms or some chest pain or some shortness of breath. And this is what a normal EKG would look like. You can see these waves kind of being upright, and this is what a normal one would look. And if you have somebody who has hypertrophic cardiomyopathy, the first thing is usually picked up is their EKG itself is abnormal. Once you have an abnormal EKG, most of these patients get further evaluations, and most of the time the further evaluation starts with an ultrasound of the heart, or as we call it, an echocardiogram of the heart. So the heart has 4 chambers, 2 upper chambers, 2 lower chambers. These are the 2 upper chambers and these are the 2 lower chambers. This is the right side of the heart, and this is the left side of the heart. And the main part of the heart which gets affected in a hypertrophic cardiomyopathy is the walls of the left side of the heart. And here you can see how the walls are very thick in this patient, and that's because the patient has hypertrophic cardiomyopathy. In addition to the thick walls, you probably are aware that we talk about something called obstruction. So this is the mitral valve, this is the aortic valve. Again, these are left-sided valves, and we are worried about blood flow getting obstructed as it tries to leave the heart, or left ventricular outflow obstruction. So obstruction, when you hear, we are worried about obstruction to the blood kind of leaving the heart, and this is where we are looking for obstruction. Once we get this echo, we kind of can see what is the degree of obstruction, if they have it or not. We can also do what is called as a stress echo. Here we put the patients on treadmill, get them to exercise, and then see, this is what is obtained at rest when the patient is not exercising, see if they have any obstruction. Again, this part is what we're looking at, and here it's kind of wide and open. And then we put them on the treadmill and see how they do, and here it gets obstructed with exertion. So this is what we do with a stress echo. We get baseline pictures before the patient exercises, put them on the treadmill, exercise them, and get more pictures. And again, we are trying to see how does obstruction change with exertion. And when you get obstruction, you can also get a velocity gradient across it. I'm sorry, the numbers are a little blurred here, but this is about 80 millimeters of mercury, so that's pretty high. So with the echo, we can see if there is any thickening, if the echo is looking like hypertrophic cardiomyopathy. Is it concerning for hypertrophic cardiomyopathy? We can see how thick is the wall. We can see if there's obstruction, and we can go a step further, put them on the treadmill, and see if the obstruction gets worse when they exercise. Usually after echo, for further evaluation, we do what is called as a cardiac MRI. MRI does not have any radiation, but it still gives very good clarity of pictures. Again, the heart, the upper chambers of the heart, the lower chambers of the heart, the right side of the heart, and the left side of the heart. And again, the most prominent muscle which is affected usually in hypertrophic cardiomyopathy is the muscle between the 2 lower chambers, called as the septum. So septal hypertrophy is what we usually talk about in hypertrophic cardiomyopathy, and there's other different kinds, but this is the most common one. And here you can see that the septum is much thicker than this lateral wall of the ventricle. So MRI, as you can see, has more clear definition than ultrasound does. So this gives us more clarity, helps us measure the wall thickness much better and much more accurately. Wall thickness is important to know because the thicker the wall is, the worse the prognosis. So it has important prognostic data. Also, if you're planning either septal ablation or you're planning surgery, then having this kind of detail anatomy makes a difference. Again, this is another view of the same heart. This is the mitral valve, the aortic valve, and again, this is the left ventricular outflow tract, and this is the obstruction that we are looking for. And the white here kind of shows that there's obstruction. So again, MRI can tell us about the wall thickness more accurately than echo does. It can also show us if there's any obstruction. In addition, we give contrast and we get more pictures of the heart after giving contrast, and here we are trying to see if there is any evidence of any scarring of the heart. So normal myocardium, normal heart muscle should be black like this, and these white dots that you see is something that we see with hypertrophic cardiomyopathy. This is pretty much a classic abnormal scar pattern that you see with hypertrophic cardiomyopathy, and that's diagnostic. This was described in pathology long back We are able to see it on MRI right now. Again, you can see that the wall is much thicker in the septum compared to the free wall. And then you can see this patchy enhancement is what we call it, but basically that's the scarring that you get because of hypertrophic cardiomyopathy. So that was, the most common one that we talk about, or the septal variant of hypertrophic cardiomyopathy, but you can also have other variants of hypertrophic cardiomyopathy. This is another very common one that we see. It is called as the apical variant. Here, initially the whole apex and the mid part of the heart gets thick. Unlike the other one, this wall is pretty thin here, but this whole thing gets thick. As the disease progresses, this gets all thinned out, becomes like a sac, an aneurysmal sac, and this is what is apical variant of hypertrophic cardiomyopathy. So in these patients, after we give a contrast, when we get imaging of their heart, this apex is white. Again, white is scar, and so you can see the scarring of the myocardium here. In addition, to evaluate to see if they have any blockages of the blood vessels of the heart, we also do cardiac CTs, and again, this is normal blood flow happening without any blockages, but we can see if they have any blockages which can account for their symptoms of chest pains and shortness of breath. So to summarize, the HCMA Center of Excellence kind of helps because you have a comprehensive imaging program, especially at the University of Iowa. We do excellent echoes, and we can go a step further, do stress echoes, both of which will help with the initial diagnosis. Also show what is the wall thickness, is there obstruction or not, how does the obstruction change when the person exercises. For better definition and better measurements and assessment of scar, we can get a cardiac MRI to see if they have any blockages in the blood vessels or not. We can get a cardiac CT. So the comprehensive imaging kind of helps in establishing the diagnosis, helps in the management. If there's obstruction, you can treat it accordingly. If there's too much of scar or the walls are too thick, you think about ICDs. And it also helps with prognosis in terms of how they do. And that is all I have, so thank you for your attention.
Well, you came screaming in for a landing there. You caught me off guard. Thank you so much for that great presentation. I did forget to mention, and I apologize to our viewers in the web room, they are permitted to ask questions in the Q&A box. So you can use the Q&A box throughout the day to ask questions of our panelists. They will either answer in writing, or we will wait till the break and we will answer questions at that point. I will just bring up a couple of topics or a couple of questions or points on imaging. Oh, how I wish imaging was all equal and everybody's images were the same quality, but we know that they're not. Could you explain how important a good protocol for imaging is, and how many images are typically taken, we'll just say for an echo point of view, in an echo done at a center of excellence looking deeply for HCM versus how many views might be included in a community-based echo?
Absolutely, Lisa. I think it's a little hard for me to comment on different centers, but definitely in our center we put in extra effort to make sure we get the right number of views. Usually ends up being around 100 pictures per patient, but the main thing is how thick is the wall, how much obstruction is there, and the echo imaging can be very different. It's very dependent on the sonographers who are doing it, very dependent on the imaging physicians who are interpreting it. So having the right training for this is important. So you get the right views and the right angles. Again, this is very dependent on the operator. So you really need good operators for this, like you said.
And can we talk about the evolving understanding and importance of cardiac MRI and how important understanding LGE and that scar burden is to patients?
Absolutely. So again, MRI is also very operator dependent. MRI has a lot of sequences you can choose from. So to make sure you have the right sequence and the right protocol identified for the patient, so you get the right information is very important. So just like echo, you need a good center for cardiac MRI too to get the right information. MRI has a lot more clear definition of anatomy and function, and also a lot of tissue imaging. So that helps quite a bit in the prognosis and in the management. The absence of scar and the presence of scar and the degree of scar, or the scar burden, has a significant prognostic information. So according to the current guidelines, mostly we use MRI if if the patient meets criteria for an ICD right away without even an MRI scar or something, then that's pretty obvious. But if it's unclear, then the next step is to do an MRI, and the scar kind of helps decide whether you get a device or not, or what is your prognosis and so on. So it has a significant significant value in prognosis and management of the patient.
Thank you very much for that. I don't see any additional questions, so we're going to move on to Denice. And while Denice is getting her slides up, I'll give you a very quick rundown on what the poll results are, and I will end the poll. So we are all US based tonight. We are predominantly in the Midwest, but we have Northeast, Southeast, and the West covered. Of those who are participating, 53% have HCM themselves, 20% have HCM in the family, and we have 27% medical providers, 20% industry tonight. So we've got some industry folks with us. It's a little bit more than we normally see. Of those with HCM, 20% have been diagnosed in the last 2 years. About 47% of you are taking medication, 47% have ICDs, 13% of you have had septal reduction therapy, 13% are in AFib, 7% of us have lost a family member. I'm the only heart transplant in the room tonight. 53% have had genetic testing, so some opportunity there. And we have one person who's been advised to have an ICD, but has not done so yet. And for some reason, we have 2 questions that don't really matter in there. I don't know what happened with that. My apologies. So for that person on the fence on to ICD or not to ICD, maybe Denice will enlighten you and give you some information to think about now. Denice, it's all you.
Great. Well, it's a pleasure to be here. Thank you for the invitation. I'm going to talk about some differences between transvenous and subcutaneous defibrillators today. The purpose of my talk isn't to discuss the indications or the characteristics that define whether or not somebody would benefit from an ICD or not, but rather to look at the different ICD options for those people who have already been found or are likely to be found to need one of them. So this diagram shows you the 2 kinds of ICDs, implanted ICDs that are available. The one here is a transvenous ICD, which is, as the name sounds, indicates that the electrodes that are used to defibrillate go in through the veins and wind up in the heart here. Now this shows one electrode, but these devices also can have additional electrodes that go in the atrium or in the vein around the outside of the heart on the left for people who need those extra pacing features. The pulse generator, as we call it, is implanted under the skin of the chest, and the electrodes come out of the vein through the pectoral muscle and then attach to that pulse generator. The shock, people are probably aware, on television, the paramedics put the paddles on the patient's chest and they say clear, and they give a jolt that reboots the heart. Here, that shock is delivered between the pulse generator, which is an electrode, and this thicker part of this electrode that's in the heart. So those are the 2 paddles, so to speak, that deliver energy across the heart to defibrillate. In the case of the subcutaneous defibrillator, there's nothing inside the heart itself. The pulse generator is put underneath the skin along the rib cage on the person's side. Actually, this picture isn't quite accurate. It's usually put a little bit onto their back. So it's not right on the side, it's a little bit in the back. And then there's an electrode, again, a very flexible electrode that runs under the skin outside the rib cage and right up along the breastbone, all of this under the skin. And here again, you see that thicker part of the electrode that is a shocking portion. And so a shock is delivered between here and the pulse generator, which again would be back here a little bit on the back, delivering the shock across the heart. So those are the 2 kinds of implantable defibrillators that people may get. So when thinking about the different kinds of defibrillators and what features are most useful, there are some specific considerations in people with hypertrophic cardiomyopathy. One is that, of course, the defibrillator is to protect against sudden death, which means ventricular tachycardia or ventricular fibrillation. But people with hypertrophic cardiomyopathy very frequently have atrial fibrillation, which is not life-threatening, but very poorly tolerated in folks with hypertrophic cardiomyopathy. So the ability to detect and sometimes treat atrial fibrillation with a device and not mistake it for deadly rhythms is very important. Heart failure, or the accumulation of fluid because of the lack of efficiency, or as Dr. Ashwath was showing, the inability to eject blood out through that obstruction, causing fluid to back up into the lungs and legs and abdomen and such. That's very common. And some devices are able to detect that accumulation and give some advanced warning that things are getting out of control with fluid retention. Sometimes, because this is a genetic disease and the presentation can be variable, defibrillators are needed in folks that are fairly young. In other populations, most defibrillators go into people with coronary artery disease with prior heart attacks, and that generally is an older population. But with hypertrophic cardiomyopathy, younger people may be getting defibrillators. And so a consideration, of course, is what's going to happen when that young person grows and the leads, their chests become bigger. And then also over time, how many times they're going to have to change the generator to get a new battery, and whether the leads will wear out with prolonged use. Now, as Dr. Ashwath also showed, the electrocardiogram with hypertrophic cardiomyopathy is usually markedly different than that of most other populations. And that can present some unique challenges to how these devices detect the heart rhythm. They detect it differently. The transvenous ones detect it from inside the heart, which is a little bit more specific and less sensitive to the unusual shape of the EKG. And the subcutaneous ones are detecting it more from a view like a EKG, and so they can sometimes get tricked by the abnormal findings on the EKG. And then in some cases, pacemaker features are needed, particularly in older folks who generally may need pacemakers, but also in particularly in hypertrophic cardiomyopathy patients who, especially those who may have had a septal myectomy or an ethanol ablation, which can damage the heart electrical system that synchronizes the chambers. So as far as just some comparisons between the different types, the transvenous ICDs have a little bit longer battery life than the subcutaneous, but they're pretty long. The transvenous ones detect abnormal rhythms a little bit faster because the electrode is right in the heart, and so it doesn't have to do as much ruling out of other rhythms. It becomes very clear quickly that that it's VT or VF, whereas this one relies on that surface EKG, so it needs a little more data to make a decision. And because this device, the transvenous one, is in the heart and very close to the heart, the amount of energy it has to deliver to get sufficient energy to the heart is lower than this one that's further away from the heart. So this one has to have a bigger battery, bigger capacitor, and it takes a little longer to charge up. So because of that difference in time to recognize and to charge, this one delivers, it takes, let's say you go into an abnormal rhythm, the subcutaneous device will take a little longer to recognize that rhythm and deliver a shock. Now, there are some good features to that. It means you're less likely to be fully conscious when a shock is delivered, and shocks are unpleasant if you're fully conscious. There's, snap of a finger, it's very quick, but people have been known to cuss. It takes a little longer, so you're less likely to be fully conscious. On the other hand, that's also a downside because you can hurt yourself if you lose consciousness. And so getting treatment earlier before you fully lost consciousness may prevent injuries, head injuries, car crashes, et cetera, that occur because you lose consciousness. So there are pros and cons to both of those. Inappropriate shocks refers to getting shocked for a rhythm that's not fatal, for instance, atrial fibrillation. And interestingly, the inappropriate shocks are a little less likely with the subcutaneous device. And probably that's because the detection is longer, so it has more of a chance to exclude that rhythm. Both of them are able to detect atrial fibrillation and alert your care providers that you've gone into atrial fibrillation. In the case of transvenous, like I said, it can detect increases in fluid retention and alert your clinicians that heart failure is beginning or impending. Currently, the subcutaneous devices don't have that feature, but it could come in the future. As far as the pacing abilities, there is a lot more functionality with the transvenous device, because as I pointed out before, you can put extra electrodes in the atrium or on the left ventricle here. And I won't go into all the details of that. You can see on the slide here, but there are many reasons that those extra electrodes are helpful. There is pacing with the subcutaneous defibrillator, which is used usually right after shock because the heart can be stunned for several seconds and the device can pace. But because it's located outside the chest wall and with in order to pace the heart, it also paces the skeletal muscles of the chest. So it's uncomfortable and it causes some twitching sensation. Whereas pacing with the transvenous, you can't feel it at all. Your heart doesn't have that kind of sensation and the skeletal muscles are not affected. And then for implant considerations, anybody can get a transvenous ICD. They are the standard, and frankly, most defibrillators that are implanted are the transvenous. The subcutaneous requires a screening process to make sure that your EKG is not so abnormal that it confuses the device. And so there's a process where you come in and get some electrodes applied to your chest, and then you sit up, lay down, a bunch of different positions, and they measure what the device would see as far as your heart rhythm and make sure that you qualify. Now that has been done successfully with patients with hypertrophic cardiomyopathy. And if you pass that screening, the function of these devices is shown to be quite good. There have been some publications on that. The implant complications, for major complications, death, heart attack, stroke, major bleeding, it's less than 1% for both of them. The main difference is that if this one gets an infection, it's just a skin infection, and often you can leave the device in place while you treat the skin infection. If this one gets infected, it creates a high risk for that infection to travel down the leads or attached to the leads and then affect the heart valves. Heart valve infections are very deadly. And so if this device gets infected, we have to remove it. And removing it is much harder than putting it in after the first year or so. Now, fortunately, infections are rare, but that is a consideration. If people have had infections in the past, oftentimes we'll consider the subcutaneous device. These devices are smaller than these ones, but the sizes are getting closer together. There are options in both cases for petite or very thin people to use special implantation techniques for cosmetic reasons to make them a little less obvious. And maintenance is very easy for both of them. Both of them are MRI compatible. The generators here are easy to change when the battery runs out. Sometimes adequate slack may be an issue for the transvenous devices with very, very young people. But both are used in all populations with great success. So everybody's situation is different and unique. I can't tell you which device is best because in some situations, one is better than another for your unique situation. So discuss it with your electrophysiologist, and hopefully this talk will give you some questions and ideas to discuss when it comes time to review this in your own particular case. And with that, I thank you.
There you go. Sorry about that. I was a little bit delayed there because my mouse didn't want to move. So as ICDs are the new thing in town, but is there anything else coming up? Leadless devices, different types of devices. Can you speak a little about that?
Sure. So there are new versions of these devices coming out all the time. The technology, the pace of technology is just breathtaking. Just like all the other technology, things are getting smaller, smarter, fancier. There's more interaction with the patients themselves, more data that they can get. Hopefully a lot of this, data you'll be able to get on your smartwatch, your phone at some point as well. There are leadless pacemakers. And now there's not really a leadless defibrillator yet, except I would consider the subcutaneous one to be leadless because there's no lead in the heart. So, so that's a nice feature. Hopefully we'll be getting defibrillators that are painless at some point. I did mention that defibrillators, when they deliver a shock, I don't know if anybody's ever grabbed an electric fence, but it's not fun. It gets your attention if you're conscious. And so there are some new technologies that people have been studying to create painless defibrillators. When that'll come out, I don't know. But there are a lot of new technologies people are working on all the time. And I really see it as becoming safer, easier, and more tolerable for people as time goes on.
So in all of the years I had an implantable defibrillator, I never received an appropriate shock until, and it was an inappropriate shock at this point, the day after I got home from my transplant and I had my ICD in my hand. Unfortunately, they left it on and the leads were frayed. And that was live on Facebook, just so you know.
Oh, gosh.
So if you go into the HCMA group and you go back to February 15th, 2017, you can watch me looking very surprised and stunned as I received a shock from a defibrillator in my hand.
Wow.
It was a kick, man. It was a kick.
Usually patients do get to, if we ask them if they want their defibrillator, some people have a whole trophy cabinet full of devices, but please ask your provider to turn it off.
Yeah, I didn't know that was something that I would have to remind them to do, but I did. So I don't encourage you to do that. We do have a question coming in. Which types and brands of ICDs are able to detect fluid retention? So the Optiball type programming. And what influences your decision to go with a certain device?
Yeah, so there are, I don't want to promote any specific companies, but there are most of the defibrillator companies, and there are 4 big companies in the United States. All of them have fantastic features and product. But the ability to detect fluid retention is becoming more common. That's a feature that is so popular that I think it's becoming incorporated in a lot of devices. And so I would really talk to your provider about which one they recommend. Part of it is it's not just the particular company and their features, but it's also what your providers are used to dealing with. And if they've got systems set up to read and interpret the measurements that are coming out of a specific company's device, then that's the one that's probably going to serve you best. But most physicians are able to deal with all the devices from all the companies, but they may have a preference based on what their setup is designed for. And I forgot, there was another part of the question.
What influences your decision for device type?
Yeah, well, I discuss with my patients all of the various features. What are their goals? What are their concerns? And also their past history. So past history is very important. For instance, somebody who's on dialysis and maybe they have their bloodstream is exposed to bacteria because, when you go into the bloodstream every day or, 3 times a week for hours at a time, the chance of circulating bacteria is very high and they're more likely to get a device infection. And so in those folks, maybe a subcutaneous device is the way to go. In most people, the transvenous device is selected because it has so much more functionality as far as pacing options, upgrades to fancier devices. And as the process of hypertrophic cardiomyopathy progresses throughout life and you get at different stages and burned out and, the needs may change and there is more functionality with the transvenous devices. So it is the default device for most people.
So the next question I'm going to ask, and a number of people do comment on, and I will start this is Pet Peeves of Lisa. The question is regarding pre-medication before dental procedures. The question here is related to does with or without an ICD matter in terms of pre-medication? But I would rephrase this to with or without obstruction should really be the question. And I will give an observation from the HCMA's point of view. So full disclosure, I had endocarditis in 1990, threw a clot, had a stroke, almost died after dental work. So I've always kind of been on the side of pre-medication. This comes into that shared decision-making piece, I think. But the guidelines were changed, about 10 years ago, and they said, oh, we don't need to pre-medicate HCM anymore. Well, we're starting to see an uptick in endocarditis and HCM again. And maybe those medications were probably doing some good, because we didn't see endocarditis didn't mean people weren't still at risk for it. Does a device play into the equation of to pre-medicate or to not pre-medicate, or is it more related to obstruction?
Generally speaking, devices do not require a person to be pre-medicated for dental procedures. Now, that being said, everybody's individual case needs to be looked at and considered. Certainly having a foreign object in your body is a nidus for infection. So the bacteria can stick to the device, live in the heart, and then grow. And then, that then allows the valve to get infected and cause endocarditis. But generally speaking, a device in and of itself does not require pre-medication. But I would definitely talk to your doctor and express your concerns and discuss it with them.
Great. Okay.
So I'll just add, if you don't mind.
Please.
So, yeah, as I think you've implied, despite the guidelines for endocarditis prophylaxis, our general recommendation has been, it's a shared decision, obviously, but especially if a patient exhibits obstruction, LVOT obstruction, then we usually do recommend that we think about endocarditis prophylaxis, and we have that discussion and we put it in our note and tell them to discuss it with their dentist. We're going against the guidelines, right? But anecdotal evidence, including some of what you decided, suggests that it's probably doing more good than harm. Go for it.
Yeah, I understand that there was an overuse of antibiotics for a period of time, but I think if you have an underlying cardiac condition and you're dealing with a dose or two a year before dental work, this is not going to lead us to, bacteria resistant antibiotic. I think they went overboard on that one. And I have had some really nasty cases that probably could have been handled with a dose of antibiotics. And I think that's a conversation people need to have and understand what the risks are, what the benefits are, and that it may be a moot point, because if you're not having any issues with the antibiotics and you don't get endocarditis, no harm, no foul. If you are allergic to antibiotics, well, then there's a whole other level of risk there. So please have that discussion with your healthcare providers. It's an important one. We are now going to get into the conversation and the age-old debate. Okay, age-old since 1996. Myectomy versus alcohol septal ablation. Is it really a versus, or are there different roles for different therapies at different times with different anatomies? Okay, Sid, do you have your screen up? But we need to switch to display setting so we can see that pretty presentation mode.
It says I cannot start screen share while other participant is sharing. And Denise might have to stop sharing.
Denise, I need you. Stop. Okay, so now Sid, go. Sorry.
Okay. All right. Well, hopefully it's going to work this time.
Fingers crossed. Technology always keeps us on the edge of our seat, people. Looks like we have all of our questions answered, so that's going well. And
let's try again.
The drum roll. There we go.
Perfect.
We are getting somewhere.
While I was waiting, I kind of figured out that the way to do it on the iPad, I was Googling all that stuff, but now we'll just stick to this one next time, probably.
Next time I'll have you be my consultant on that. Thank you.
All right. So hello, everyone. I'm Sidakpal Panaich. I'll be talking about, the age-old debate. Again, it's less of a debate, but like there's, as Lisa just mentioned, there's a role for everything. I'll just kind of briefly touch on, why it's not so much of a debate as it's also been realized by the ACC. All right. So I have no conflicts of interest. To start off, septal reduction therapies, when do patients need it? It's pretty much remained the same over the last decade or even more for the last 2 decades. And we mainly need it when patients are symptomatic despite adequate medical therapy. And what that means is the 3 things. When you have heart failure, when you pass out or are going to pass out, syncope or near syncope, and you have chest pain despite having being on optimal medical management. And something is is I think I was in 2021. Mahi's making fun of me. Okay. And the other thing is, we can't really tolerate medications. That's a real thing. This doesn't go in the guidelines, but again, we have to have discussions with our patients because they might not be tolerating the beta blockers or calcium channel blockers and so on and so forth. The septum of more than 15 millimeters is, again, a little bit of a guidance for us as interventionalists and the surgeons, because you need to leave something behind. You just can't take away all the septum. So we need a little bit of a thickness of the septum to do a procedure to be safe and effective. And again, from physiology standpoint, we take a cutoff of resting gradients of more than 30 and provoke gradients across the LVOT with Valsalva of more than 50. So just a little background, alcohol septal ablation was always like a class 2 or 2B guideline in the 2011 guidelines. Then came along the ESC guidelines in 2014, which gave it an equal class 1 indication. Now the 2020 ASCC AHA guidelines have been updated, and both surgical myectomy and alcohol septal ablation get a class 1 indication. And notice it's very important, even though the class 1 indication, the ACC says that yes, if you want to get surgery, it might be better in patients who have need for concomitant surgical issues, like if you're going to get a bypass, if you're going to have mitral valve repair and so on and so forth. Treated, yes, surgery might be a better option. If you are high risk for surgery, then alcohol septal ablation would be an indication. Nowhere in these guidelines they compare the two and we'll talk about it. So they don't say which one is better than the other. They say, yes, this is better in this population and this is better in this population. What about which patients which might be candidate for both? They don't mention that. And there's a reason for that. So, alcohol septal ablation in the last decade, what's the first issue? Alcohol septal ablation has had very similar hard clinical outcomes. People get symptom relief and YHA improvement as surgery does. So, when indicated, they both could, it should be done. Less concern about late events, that was probably concerned. We have data for alcohol septal ablation for up to 8, 10, even more years. And mortality and, sudden cardiac arrest has been exactly the same in large registries. So let's talk about these first 2 points. From, as far as heart failure and improvement in outcomes goes, this large 629 patient study that was done from 96 to 2007 from Baylor in South Carolina showed that, the gradients decreased and stayed the same in patients up to 10 years. Their treadmill test, the NYHA class, their CCS angina, so their treadmill scores stayed improved up to 10 years. The NYHA class and CCS class remained low up again to 10 years. Survival, when you compare alcohol septal ablation to surgical myectomy, we'll go starting back from Dr. Siraj's work in 2030 from Olmsted County from Mayo Clinic. The survival up to 8 years between myectomy and ablation stays about at 80% for both cases. This data from Europe shows the same data exactly. The mortality is exactly the same between 2 patients undergoing alcohol septal ablation and surgical myectomy. Another study from Europe, from over 1,000 patients in Europe, by the way, most patients end up getting alcohol septal ablation. So their practice patterns are way different from the United States of America. But, so we have a lot more data that comes out of Europe for alcohol septal ablation. So in these more than 1,000 patients, that people were compared between medical therapy, asymptomatic patients, medical therapy, those who got alcohol septal ablation and myectomy, up till 10 years, the survival and certain cardiac arrest was pretty much the same between these 3 patient populations. Absolutely no significant difference between these 3 patient populations, those who were treated with medical therapy, alcohol septal ablation, or septal myectomy. Again, just not to bore you, but just last couple of slides. These, again, were both separate studies from separate centers. This was from the European data, about close to 1,000 patients. This is from the Czech Republic. I know Dr. Veselka pretty well. This, again, 80% survival rate up till, again, 10 years. And in this case, more than 15 years for patients who underwent alcohol septal ablation. So basically, all these studies have consistently shown in all different patient populations, very large registries, over 1,000 patients, over 10 to 15 years of data, showing that basically all of them had more than 80%, whether you compare it to myectomy, whether you compare it by itself, or you compare it to just medical, treatment. So the survival rate has been excellent after alcohol septal ablation. The meta-analysis from Cleveland Clinic showed that there was no difference between, between myectomy and surgical and alcohol septal ablation in short or long-term survival, in functional status improvement, in YJ class, in arrhythmias, rate of repeat procedures, or mitral regurgitation severities after that. There is one Achilles heel of alcohol septal ablation, which some of you might know is the higher need for pacemaker and slightly higher residual gradients, for which reasons we continue, and we'll talk about it, to suggest that people who are very young probably are better suited off for both these reasons with septal myectomy. Same thing was seen in another meta-analysis that was done later, published in JACC, which showed basically no other difference in heart outcomes, but alcohol septal ablation continues to have higher rates of pacemaker. And this one showed that probably reintervention might be required in patients who go alcohol septal ablation. So again, something that, if you're young, septal myectomy might be preferred to avoid reintervention and maybe lower rate of pacemakers as well. So, the second point is the concern about lack of surgical expertise and poor real-world myectomy outcomes. So, this earlier paper showed that the operative mortality is less than 1%. And, Dr. Marin always quotes this paper, and so do my previous mentors from Mayo Clinic. But that's all good and dandy if you take, the centers of excellence, Mayo Clinic, Cleveland, and these 5 centers, the 4 centers mentioned over here. But what about the national? This is actually a paper that I published back when I was a fellow. You look at the real percentage of mortality in a real world population. It approaches 6%. 6% is a huge mortality for any surgical procedure. So, and we basically looked at very similar years for septal ablation, and from the very same data, guess what the post-procedure mortality was? 0. 0 in a very real world unselected patient population. We're not talking about who got it. Technically, people who are supposed to be higher surgical risk are supposed to be getting with way more comorbidities, but you had a post-procedural mortality of 0 in these patient populations. So yeah, it's less than 1% in people who get their septal myectomy at Mayo Clinic. But what about people getting it in just regular sites across the US? And then, there's always this physician, hospital volume, and patient preference are also important, right? So why is that? The scope of the problem. The first thing is rarity. We know that HOCM, fortunately, is a very rare problem. Not a very, but it's a rare problem. Then majority of the patients, again, fortunately, are asymptomatic or mildly symptomatic. A lot of them, again, can be managed with medicines. And Dr. Ahmad does a great job, right, in our HOCM Center of Excellence. So only 50% of these patients are going to need some invasive therapy. And a lot of them are going to be candidates for myectomy, and a lot of these are going to be candidates for alcohol septal ablation, right? So majority, as I said, in alcohol septal ablation in Europe get alcohol septal ablation. It's about 50-50 split across the United States, depending on the centers and where you are. So if you were to do an alcohol septal ablation or myectomy, you would have to see about 10 patients, right? And so to maintain why I say 10, so you can calculate, you do the math, you would have to approximately see about 200 patients a year to even get to about 10 alcohol septal ablation. And 10 is the number that is suggested by both HOCM guidelines as well as the SCI and ACC competency guidelines. So for me to be a competent septal ablator, I have to be doing at least 10 procedures a year for alcohol septal ablation. So which means Dr. Ahmad has to see more than 200 patients a year for me, right? So complications in alcohol septal ablation. So why are the numbers important? The first paper from Dr. Saraja showed that these hospital volumes, these are not per operative volumes, but people who had done accumulative alcohol septal ablations of less than 50 and then compared it to 50 to 100 and more than 100 showed that their acute hemodynamic success was better and their survival free of symptoms was better. So 50 was a sweet endpoint, so not a sweet cutoff, where you at least had to do about 50 of these procedures before you were getting actual really good results out of your procedures. This was again our paper where we showed that when we separated those 7-year experience in tertiles, hospital volume tertiles, we showed that any complication, any cardiac complication, as well as pacemaker placement was significantly better if you were in the highest volume tertile. And then so this again, basically shows compare across the tertile, this is the highest volume tertile, and so on and so forth. So basically your volume matters. Same thing was basically replicated by Dr. Kim and Dr. Naidu and all their group and published. Little later, they added some more years to our experience, and again, showed the same thing. Your mortality is better as you go higher in volumes, higher volume centers. Your bleeding, renal failure rates, pacemaker rates all are much improved. I'm going to skip over this part. So actually, I'll kind of quickly go over this. So basically, what this slide is showing is that as we get more experience, we realize that we've started putting in temporary pacemakers, so like active fixation pacemakers. The reason for that is a lot of people will have a complete heart block. A lot of people will develop complete heart block as we go alcohol septal ablation. And initially these people were considered for a pacemaker. But if you leave these temporary pacemakers that we are able to leave in patients, once you get beyond a few days, look at the rate of frequency of people who require permanent pacemaker. As your conduction system gets better, inflammation and your inflammation in that area gets better, you're very unlikely to require a permanent pacemaker. There was, alcohol septal ablation was always maligned for scars and ventricular arrhythmias. Study came out of a 25 patient study where horrendous amounts of alcohol was given with, because people didn't know any better. However, this, Mayo Clinic study showed that there was no mortality attributable to sudden cardiac death in patients who underwent alcohol septal ablation. Another meta-analysis of a large number of patients basically showed that there was no difference in all-cause mortality or sudden cardiac death between alcohol septal ablation or myectomy. Alcohol ablation patients were all older, so expected mortality was higher, but which was not the case. Both appear to improve survival. So, all that theory is now, if you read the guidelines that, again, I showed first in 2020, basically says the same thing. There's absolutely no difference, absolutely no proven difference as far as mortality or sudden cardiac arrest goes between the two modalities. Predictors of success, this was the first paper, basically simplifies Dr. Suraj's paper that, people who were older tended to do better with alcohol septal ablation, but who were less old tended to have, re-interventions. And so their overall survival was lower if they got ablation. And so this was one of the first papers that basically shows that if you're young, and especially less than 60, 65 years of age, you might be better suited up with myectomy. And that basically goes to the fact that you get better gradient reductions with myectomy in these patients. It also is important that we, predictors of success says less hypertrophy. So if a patient has a very thick septum, they're better suited up with myectomy. One, they get better reduction. Two, there also is with alcohol septal ablation, we tend to cause in those patients probably a higher risk for arrhythmias by causing a big infarct. Resting gradients, we prefer less than 100. Again, this goes to the second part. You're going to have a high gradient. Most likely, you have a very thick septum. So, just to end these things, alcohol septal ablation. What do just if you're going to remember, what is it best suited for? People with multiple comorbidities, those who are older, depending on what guidelines you read, whether it's CSE or ACC guidelines or what kind of paper you read, could be 50 or 60, but basically older people who have failed myectomy. I'll show you a couple of cases to end the presentation. People who have had prior open heart surgery, those who have a perfect anatomy. What is a perfect anatomy? We like focal for alcohol septal. They can be done if they're not myectomy candidates, but usually our chip shots are focal thickening. And people who have prior pacemaker and ICD, because again in the Achilles heel for alcohol septal ablation is pacemaker and ICD. So if you already have a pacemaker, your other complication rates are pretty much negligible. Septal myectomy, young patients less than 50, almost a no-brainer. You're very young, you are athletic, you want to compete. And so this is something that is better suited for myectomy. Massive hypertrophy, we already talked about it. Patient needs surgery for something else. You've got a large redundant anterior leaflet or pap muscle issues and whatnot. So, septal myectomy is better. If you need bypass surgery for some reason, all those things concomitant surgical requirements, surgery is better. And then there will be a few straightforward patients who could go either ways. And so right now the guidelines basically have an equipoise at this point. So you need to have a discussion with your physician about it. So there's no thing like, you have to be a prohibitive surgical risk to go for alcohol septal ablation. This is a very honest discussion that you need to have with your attending on what the pros and cons of each are going to be. So just a couple of cases, just take a couple of more minutes of your time. So this is one of our patients that how we do alcohol septal ablation. This is your left anterior descending artery that runs down. And we identify the first septal perforated directed towards the LV. We, which is adequately sized, inflated to make sure that the dye that is being injected does not go back and leak back, or I'm sorry, the alcohol that is being injected does not leak back or cause any infarct in an unintended area. This is all being done with echo guidance. So we see that, you can see that the septal bulge here is being lighted up, and only the septal bulge is being lighted up. I've not shown you other pictures, but we take very careful pictures on echo to make sure that, this is definity that is being lighted up before I inject alcohol, that only the intended area is being lighted up on that part. So this is the same patient. You can see the septal bulge right here. That was there. This is the patient that I saw over a month later, and you can see the whole somebody took a bite out of it. So the initial gradients were 52. This was his Valsalva gradient right before the procedure, and this is his gradient. It doesn't say, so I think it was more like post-provoked gradient was like 17, and his baseline gradient was less than 10. And so, again, I was talking about the surgical expertise. This is a patient who has had myectomy, and my arrow points to the area that had the myectomy, but had it a place that they did not extend the myectomy properly. Look at the Valsalva, this is the baseline gradient. This patient had a baseline resting gradient of 125 on echo right here. And this is patient follow-up after several months. You can notice this place that I have marked. We ablated this place, and now you have a full-on area without any septal, without any SAM, which is systolic anterior motion of the mitral valve. And now you have a resting gradient of 17, down from 125 in this patient. Again, another patient that had septal myectomy, and we saw a patient after septal myectomy. You can see the area of possible myectomy, but this patient again did not had a myectomy that was done at a center that did not extend it down, and you see this whole bulge that is still present. This is a little bit of a more tricky situation because this patient has a more diffuse, technically again first suited for myectomy, but at a probably a surgical center of expertise that should have extended it, because this is now we're getting into a mid-septal zone, a mid-ventricular zone. However, we were able to find a septum. You can see the septum is, the septal perforate is being basically milked by that by the thick muscle, and so we had a very good septal. We injected into that. You can see the whole area, just as I showed you before, light up, and we had a balloon here. And because we use a special technique on this one because of the, you see a multi-purpose catheter, which is a catheter we use to, detect the end pressure beyond this thick muscle, but usually gets entrapped. We get a lot of artifacts. So we use a special wire for a high fidelity measurements across this, again, the part that was septum. So we saw a pretty, good reduction. The patient is to come back follow. We're hoping for good results. So conclusions, we can get excellent reductions with alcohol septal ablation, and with more, experience, we were able to get surgical-like results, especially in patients who could not, might not be good surgical candidates. Long-term survival has never been shown to be different. It's a rare thing. There's never going to be a randomized trial between the two, but we have ample data to, that has never shown any difference between the two. If you were to really pinpoint, obviously, more older patients with less LVH, which is left ventricular hypertrophy, resting gradients that are not that high, at experienced centers with acute hemodynamic, will achieve better hemodynamic success. Questions? Thank you. Hopefully I didn't go crazy.
I'm sure we're gonna get some questions. Okay, let's see what we've got here. So the question is, opinion on volume mattering, data as a person that was at one, I'm not going to name the center, and now at another center, I'm guessing performed significantly less alcohol septal ablation. I just want to take a moment here to highlight a couple of critical issues related to the decision for septal reduction therapy and which way it flows. Anatomy drives the conversation probably 95% of the time. Either you have the proper anatomy to warrant an alcohol septal ablation or a myectomy. And when you look at all data and you look at the general numbers in high volume centers, most patients have a better anatomy and better outcomes with myectomy. But it can be safe to do alcohol septal ablation if the anatomy allows it. If the hypertrophy is in the wrong part, or the papillary muscles are the problem, or if the mitral valve is coming back to hit the septum rather than the septum hitting the mitral valve, you're going to have a better result with a myectomy. So it's not just about what you want. There was an article written many years ago that most patients prefer alcohol septal ablation. Well, duh, you don't have to crack your chest. Of course we prefer that. Nobody wants to do that. So what you want isn't always what you need. So you really need to go to a high volume center that has a team approach to evaluate your anatomy and find the best solution for you. So that being said, even at the highest volume HCM centers, you're talking, I think Mayo's volume from alcohol ablation is under 30 a year. So you see a 225 myectomies and 30 alcohol ablations. They have the ability to do both. Kringlen is the same kind of numbers. Tufts is the same kind of numbers. So I want people to be really careful about understanding what you have a choice in and what your anatomy dictates. Sid, what do you think?
No, I think it's a great point. I would just like to say that, yeah, the anatomy dictates it. So again, the first thing is a lot of patients will have papillary muscle and mitral valve issues and stuff like that, and they're best suited for septal myectomy for sure. So as I pointed out in my last slide before I was showing cases, that there's going to be anatomy dictated issues, and then there's going to be people who are not going to have coronary perforators. So there's at least about 20% of the people that are not going to have suitable coronary perforators, and there are going to be people who are going to have other issues that you need surgery for. But once you compare, and again, you can correct me if I'm wrong, but once you compare the two, people who can get myectomy and people who can get alcohol septal ablation, and they get it, I don't know of any data that has shown that one's better than the other. And that's why the ACC, Dr. Ullman and Mayo Clinic's group has actually pointed out, has taken that away. ESC took that back away in 2014, 6 years ago. ACC always falls ban in every guideline in heart, and they followed suit now. They basically refuse to compare the two modalities because they know there's no data saying that one's better than the other. Yes, if you don't have the anatomy, that's a different issue, but there's absolutely nothing. And in Europe, there's a reason that it is the preferred modality. And they have ample experience. I mean, almost everyone in Europe does alcohol septal ablation. They have way more experience. That's why they're able to publish 1,000 people studies all the time. I know Dr. Marin has pushed myectomy a lot in over here, but I mean, I still, and correct me if I'm wrong. I mean, show me the data which shows that it's
so
better.
I will point out one major difference between the European and the US experience. There are hardly any surgeons in Europe who do myectomy. It's just been, we've lost the art. It's starting to rebuild again out of Italy and in Sweden and in a couple of other places. But the number of skilled surgeons who can do high volume myectomy because they're getting that patient flow, it shifted in the 90s, and they were doing way more alcohol ablations there. And the patients in Europe who are getting some of these alcohol ablations, I hear from them when they're not happy. They don't show up in the data so much, and we're trying to rectify that. So there are some issues with patient outcomes that are not necessarily adequately reported, in my opinion, and patients would benefit from having better reduction of gradient to improve their quality of life. So there's some issues out there that are yet to be resolved here. But I think we're probably talking about a point that will continue to be a little bit controversial for a little while. Which way do you go? But then we're going to throw mavacamten and aficamten into the mix, and we're going to have better medical therapies for obstruction. So I think the take-home message is there's a lot of options available for obstruction, and going to a high-volume center to evaluate what all of your options are and figuring out what the best treatment for you is. You don't want to have a low-volume myectomy. You don't want to have a low-volume alcohol septal ablation. I'll argue that their numbers were a little, I think the numbers that they use for competency in both alcohol ablation and myectomy are a little low from my point as a patient advocate, saying doing 10 or 20 is good enough per year versus 30 or 40 myectomies. We like those numbers higher. We want people doing this every day. We want them to know this cold and be able to do that great procedure that we're looking for. So I think patients are well advised to participate in shared decision-making, to understand their own anatomies at the deepest level possible, to make the best decisions for themselves on what they want to do about their obstruction. And there's never going to be an answer, and there will never be a randomized study going head to head here. It wouldn't be ethical because the patient populations are very different. The older will do better with alcohol ablation, and doing a younger alcohol ablation, I've been around long enough to have seen some of the earliest ones, and I've seen people that were in their 20s and 30s have them done way back when. Long term, they don't do well. And we want to make sure that we're not doing this on too young of a population. And I think we all agree that 50 and over, 55 and over, it's an option for either. But it's a complicated decision for people to make because nobody wants their chest cracked. Nobody wants that. The Zipper Club is not one that everybody wants to join. So I hope that answered your question, Coraline, and we can get on to any other questions, but I don't see any popping in. No other questions. Yay. We're doing well at answering their questions as we go. That's a good thing. So any parting thoughts from anybody else on faculty? To ablate or to cut? The never-ending question. Okay, then we're going to move on and we're going to start talking. We're going to geek out on genetics now, people. One of my favorite topics, I have to admit. Not that I don't like the other topics, but genetics just evolves like every 10 minutes. So what are we doing with genetics and who's taking the lead here? Maggie, Gabe?
Yep, I'll start off.
Okay.
So I'm Maggie Freese, and myself and Gabe Kringlen are genetic counselors at UIHC who see a lot of patients and families with hypertrophic cardiomyopathy or HCM, and we wanted to spend some time discussing just one aspect of genetics within HCM, and that's the implications of genetic testing within a family with HCM and how certain results can impact the recommendations for screening in family members. So to start off, we're going to kind of review some basics of the genetics of HCM very briefly. We know that there are multiple genes associated with HCM, and that typically how they're passed through a family is in a pattern called autosomal dominant. And when you break those terms down, autosomal just means that males and females are equally likely to have the condition. And then for all of our genes, we have 2 copies of every one. We get one from our mother, one from our father. So in a dominant condition, that refers to there being one genetic change in one copy of the gene. So you have one copy that has the alteration or the mutation, and then the other copy that does not. So just having one copy of the change is sufficient for an individual to develop that condition. So in a classic autosomal dominant pattern in a family history, what you'll see on the right is that individuals in blue are those that are affected, and men and women are both equally likely to have the condition, as you can see in that diagram. And they're both equally likely to pass it on to their children. It doesn't matter male or female who has it, and then it doesn't matter who they pass it on to. So it's very straightforward in that manner. And then throughout the family history, it doesn't skip generations. So if it's there, usually what you'll see is that it's present in many different people, many different generations of family. However, within HCM, we know that that's not always the case. Although it's inherited in that same pattern, for some reason, not every family is positive. very often we have patients that come forward that have apparently negative family histories. And that's because of, mainly because of two different phenomenon in genetics, and that's reduced penetrance and then variable expressivity. In regards to reduced penetrance, penetrance is a term that refers to the percentage of individuals who have the genetic change who then go on to develop the condition. So in a condition that has 100% penetrance, that means that everyone who has the genetic change then develops the condition. However, we know that in HCM, that even if an individual has the genetic change, they don't always develop HCM signs or symptoms. So it's reduced. We don't know an exact number for that right now. The other phenomenon is variable expressivity. So one way that you can define this term within HCM is that it differs between person to person and how it presents. So age of onset, for example. So for one individual in a family, if they have HCM, they may develop signs or symptoms in their 30s. For someone else, signs or symptoms may develop later on in their 70s. It just differs between related individuals as well as between unrelated individuals, even when they have the same genetic cause. So within HCM, you can see that it can often skip generations, but we know that a lot of these people, or throughout family history, that a lot of people who don't appear to have disease can still have that genetic change underlying it. And so this can really complicate our screening recommendations for family members, and it can make it a challenge to identify those who really do need to have cardiac screening routinely done. Because again, there are most likely individuals at risk within a family that are unaware of their risk because of the lack of signs or symptoms, and then the possible later onset of disease. So a part of our role is to incorporate genetic testing into healthcare, and genetic testing can be a really good option as a solution in identifying those at-risk individuals. In about roughly 50% of individuals, we can identify a known disease-causing change that can be underlying their hypertrophic cardiomyopathy. And that information can help us to use that to test other people in the family. And because of that, we can then identify those who are at risk of developing the condition, and we can test them with genetic testing rather than relying on just clinical screening throughout their lifetime. And so in this way, we're able to promote the detection of hypertrophic cardiomyopathy. We can clarify an ambiguous diagnosis within an individual. And then we can also direct individuals who are in need of increased surveillance or those who need some sort of preventative intervention, like an ICD, and direct them to the appropriate providers for that. Another really big benefit to it is that it provides information for family planning too, and that can be a very big and important piece for young individuals in a family who are aware of their family history of HCM. On the other hand, if you have a family member who tests negative for the familial change, the genetic change that's causing HCM in the family, that can be very powerful information too, because it can alleviate that burden of having to undergo routine clinical screening, and also possibly alleviate some of that anxiety that they may have of the uncertain or unknown future of whether or not they may develop HCM in the future. So I will pass things on to Gabe, who will go through a couple of cases to emphasize a couple of different testing results and how they impact screening in a family.
All right, thanks so much, Maggie, for the great intro and overview. So what I'm going to do here is show a hypothetical family. This is not an actual family that either Maggie or I have seen in clinic, but we put it together because I just think it can help illustrate a lot of the different concepts that we are trying to illustrate here. So in this hypothetical family, we have a patient here who is a 45-year-old female who was recently diagnosed with HCM. And so you can see her pedigree or family tree here, and you can see all the other symbols that are shaded in red are this person's relatives who are also confirmed to have had HCM. Her mother passed away in her 50s, had HCM and had a myectomy. And then there are two aunts that also are affected with this condition, one of whom is still living, the other is deceased, as well as a cousin who is age 54 infected. And then also point out a couple other individuals here in this pedigree. You'll notice that there is a maternal uncle who died at age 52 of a, quote, heart attack, but no autopsy was done. So as genetic counselors, we often view that fairly suspiciously, where we think, well, was that really a heart attack, as in a myocardial infarction, or was it something else like sudden death related to HCM? The same thing applies to this person had a maternal grandmothers had a few brothers, so this would be great uncles of our patient who had a similar event potentially happen, as well as maybe even having an enlarged heart that was observed on autopsy. And then finally, this person has 3 siblings, 2 sisters and 1 brother. One of her sisters has already had a normal echocardiogram a couple of years ago, no evidence of HCM at the time. The other 2 siblings have yet to have any sort of screening or imaging done. And then finally, our patient has 2 children, a daughter age 12, a son age 15. And neither of these individuals are known to have HCM at this time, but they haven't yet had screening. And then just before we go any further, I'll just point out that let's say we see this patient, we order a genetic test, and we find a positive result, which refers to a known HCM or disease causing change. All right, so when we get this person's genetic testing result back, this is what the report might look like. So at the top here, you'll see result is positive, and then it describes that 1 pathogenic variant was identified in a gene called MYBPC3. Now, this is one of several different genes that can be associated with HCM, but this is, out of all the genes, probably the most commonly involved gene with this disease. It accounts for about half of the cases that we can find a clear genetic cause in. And so I'll point out a couple other things on this report. You'll notice that not only do we need to know the gene that's involved, we also need to know where in the sequence of that gene that specific variant or change occurs. So where it says C.1504 C to T, and then next to it P.ARG502 TRP, that's essentially telling us exactly where in the sequence of that gene that change occurs. So at position 1504, normally there's a letter C, but one of the 2 copies of that gene, as shown just to the right of that nomenclature where it says zygosity, heterozygous just means that one of the 2 copies of the gene has that particular change. The other copy of the gene does not have that change. And then finally, variant classification, and this is important. There's enough evidence in the literature to strongly support that this change truly does cause HCM. And it takes a lot of data to get to that kind of classification. But once we have that data, it makes it very valuable for screening other people in the family, as we'll see in the next slide. All right, so going back to our hypothetical case here. So how can we use this, our patient's genetic testing results to screen other people in the family? So one of the main important points to emphasize on how genetic testing would work differently for our patient's relatives is that rather than doing a broad approach looking at many different genes to see if we can find that proverbial needle in a haystack, all we're doing is bookmarking 1 page in 1 specific book. And we're looking to see who else in the family has that exact same misspelling on that exact same page and which family members do not. And so going on to the next slide here. So this would be an example of what might take place. So let's say we go back and we test all these other relatives. So we can start with our siblings here. Let's say that, both sisters underwent testing for the known HCM causing change. One of the sisters was positive, the other sister was negative. And then if we went further, we tested some cousins. We find that, not surprisingly, the cousin that's still living was positive for the same change. That really is kind of what we expected. But more importantly, perhaps you'll notice that there are several relatives, cousins, as well as our patient's sister who had a normal echo a couple of years ago. There are some relatives that appear to be unaffected or don't have any known HCM at this time, even may have had an echocardiogram a couple of years ago that looked quote unquote normal, which it probably was. But we know that those individuals with that little plus sign next to them do have that same increased risk of developing HCM. Now, as Maggie pointed out earlier, the people that test positive are not guaranteed to develop HCM, but those people would need to be followed carefully by a cardiologist and be screened, typically every year to every couple of years to make sure that we're not missing anything. And then one other thing I'll point out is that this person, thankfully, Her two children tested negative. So assuming that they had at least a baseline echocardiogram to make sure we weren't really missing anything during our due diligence, we can be pretty darn confident that those two children of our patient do not have that increased risk of HCM. They would not need regular cardiovascular screening related to their family history of HCM. And also, as Maggie alluded to, they wouldn't have an increased risk of passing on that genetic change to any of their future children. All right, so let's use this exact same hypothetical patient and family. So we haven't changed anything, but let's say we did genetic testing and we found slightly different results. So sometimes instead of finding a genetic change that is proven to be HCM causing, sometimes we might find a change where we're not really quite sure what this means. So you might notice that this specific report, at the very top, it says result uncertain, variant of uncertain significance identified. So a lot of genetic counselors like to joke that variants of uncertain significance are kind of the bane of our existence, but it does keep us intellectually challenged, and it's kind of a puzzle. So anyway, I'll point out a couple of things here. Again, the same gene that was involved with the first result, but unlike the first result, we have a change located elsewhere in the gene. And this change is classified as uncertain, meaning we don't have enough data about this particular change to know if it's truly the cause of our patient's HCM, or is rather a completely harmless change that really means nothing at all. So one of the analogies that I'll often use with patients to help explain a variant of uncertain significance is to use an analogy where I might use the word gray, for example. So at least in the US, usually gray is spelled G-R-A-Y, but we know we could spell gray just as easily with the letter E instead of the letter A in that position. So the letter E in the word gray, it's kind of like a harmless genetic change that doesn't actually impair our ability to pronounce that word. We can say gray just as easily with an E as we can with an A. So that letter E, we know that the majority of genetic changes that we all have are actually harmless, that are like that letter E. But let's say instead of spelling gray with an E or an A, we tried spelling it with an X in that spot. And clearly you can't spell gray with G-R-X-Y, you need a vowel there, it doesn't make any sense. So those are the types of changes that we're really trying to find when we do this type of genetic testing. But sometimes we'll find a change and we don't have enough data to know, is it more like that E or is it more like that X? The answer's out there somewhere, but we just don't have enough data at the time. And so that would be the way that I would explain exactly what one of these variants of uncertain significance would be. So going on to the next slide, how would we use this type of result? It is quite a bit different than the first example where it's very straightforward. We can use a test, a one-time test to figure out who in the family has this risk and who doesn't. It's a little bit more complicated in this situation. So starting off, we would not actually recommend any sort of HCM genetic testing. We wouldn't recommend testing for this particular change that we found, or in any broader panel for our patients' siblings or kids. Rather, what we would recommend for them is sort of the old school way that we would screen for HCM. So this would be EKG, echocardiogram, Holter monitor, all the things that cardiologists have been using for quite some time to screen for these types of conditions. But unlike someone that tests negative for a known disease-causing change, we know that a normal screen doesn't completely rule out that risk. And so we need to recommend that those relatives that are at risk repeat that screening every few years, because we know that HCM could potentially develop at any age. So in the meantime, how might this uncertain change actually, how might we get some more information about it? So as an example, we would not want to test, our patient's children or siblings for this uncertain change, because we really don't want to potentially give any false reassurance or false alarm based on data that we just don't have very much, information about. But what we could do in the meantime is, going back to our pedigree, we could track down these two relatives that are still living that are affected with HCM to see, okay, well, they already are diagnosed with HCM. Regardless of whether they're found to have this uncertain change or not, that's not going to affect their status of being affected with this condition. So we might actually, if possible, recommend testing those two living relatives to see, does that same uncertain change actually occur in them as well? Because if it did, that would be some pretty strong evidence that, this probably is the cause of HCM, and maybe we could eventually reclassify this change. But let's say we tested both of those relatives that had HCM, and let's say one of them was negative or both of them were negative. Well, that tells us that this uncertain change probably is not what's causing the HCM in our family. Maybe it's some other genetic change that is either maybe in one of the genes that we tested our patient for, but maybe the test technology wasn't able to pick up, or maybe there's some currently unknown gene out there that no one knows about yet. Because we don't know about it yet, we can't test for it. So overall, just to summarize, when we get these types of uncertain results, we don't use it to guide relative screening until we gather more information about whether this could in fact be disease causing or not. And so with that, I think that was all of the slides that we had to share with you. So Meg and I would be more than happy to answer any questions that you have.
We've got them coming in hot and heavy here.
Oh, wow. All right.
Okay. So the first one's an easy one. Does insurance cover genetic counseling and or genetic testing? I will pause there and say currently for HCM, there is a sponsored test that is available for free from Invitae. And you can get the testing done for free, but the genetic counseling is a little bit different. Genetic counselors, speak up.
Yeah, so I think ultimately it depends on the type of insurance that you have and that you carry. And it's dependent upon your deductible, out-of-pocket maximum, all those sorts of things. So there's always the option of looking into that before a genetic counseling appointment too. If anyone has any sort of concern about if there is an out-of-pocket cost for it, we do kind of direct our patients to the patient financial services that we have at the hospital, and they can help us determine whether or not someone may actually have a large out-of-pocket cost for the appointment itself.
One other thing I'll add on the insurance and billing side of things is that it is important to emphasize that ordering a genetic test on the proband, which is just our fancy way of saying the first person who's affected with HCM that we see in clinic, that's the type of patient that we would want to use that sponsored program for, that detect program that Lisa alluded to. But let's say we find a clear genetic cause in that person, and then we're offering a targeted test for that person's relatives. We would use a kind of a different type of code, which actually Invitae would also offer free testing for that change within a certain time window. But once we're out of that time window, unfortunately, we're in a place where there isn't any sort of quote unquote free option. But we, in most cases, not all, but we would say in many cases, insurance would cover the cost of that single site testing. And if in the rare case that it wouldn't, it would usually be available, at a self-pay price. I think Invitae offers it for $200. So I just want to clarify that specific point.
Yeah, and that's part of our role as genetic counselors too, is to identify the laboratory that's the most appropriate for the genetic testing that we're ordering, as well as to identify a laboratory that would allow a lowest cost to use. Because nowadays it's very feasible to get genetic testing done at a low cost, and we want to make it more attainable to the patient themselves too. It shouldn't cost an arm and a leg nowadays.
When we began this game and the first clinical test came on board, it was $8,000 for 5 genes. And
quite a ways.
I said, if it's the last thing I do, I'm going to beat you guys down until this testing is really affordable. And even without the Invitae panel right now, there are cost caps on a lot of these panels that are $100, $200. They're very affordable. And I encourage y'all to take advantage of at least looking. Not only can you use the information for cascade screening, as you've discussed so eloquently, but there's an opportunity to find out if it's one of the phenocopies and that you have a different treatment pathway completely. So I think it's really important to try. We know that about 50% don't give us much of a response. We don't know what they are yet, but we're learning. And I encourage you all to check back with your genetic counselors on a regular basis for updates on VUSs and interpretations, and get involved there. We have 2 more questions hold up right here, right now. 50% chance of a parent with HCM will have a child with HCM ? So can you kind of go over a high vision of autosomal dominance again?
Yeah, so in an autosomal dominant condition, so as I mentioned before, so that individual who has it has 1 copy of the gene that's perfectly fine and the other copy that has some sort of misspelling. And I like to use kind of visual aids. But that individual, for any future child they have, they give off 1 copy of every gene. So it's either the unaffected copy or it's the altered copy. So it's 50-50 of which one they pass on. And that's for each individual child. So kind of a flip of a coin for your first child, flip of a coin for the next child, flip of the coin for the next.
And
So,
I want to clarify too on that. That's exactly right. And even though it's a 50-50 chance that, you know, any future child would inherit that altered or changed copy, it doesn't necessarily mean that that child has a 50% chance of developing HCM, right? We would say that that child has a 50% chance of inheriting that genetic predisposition, which in turn could increase the risk of HCM, but that person wouldn't necessarily be 100% guaranteed to go on to develop the disease.
okay, next question. You ready, genetic counselors? It's the one you knew was coming. Do different genetic mutations have different outcomes? Is there one typically more mild or severe or with symptoms or changing in mortality rates?
I can start off. The short answer to that question is overall, yes. We know that some genes can be associated with quote unquote more severe disease than others. But if we were to limit our discussion to just HCM and not other genetic cardiomyopathies, I wouldn't say that that applies nearly as much. The thing that comes to mind, for example, is we know that there's some rare genes out there that can be associated with HCM as well as other genetic cardiomyopathies, that when we find a confirmed disease causing change within those genes, that itself might be, for example, an important risk marker that could be associated with an increased risk of arrhythmias. So that's one example, not to get too much into the specifics, but yes, sometimes there can be certain genes that are associated with more severe disease than others, but I would say right now we're typically not using, most genetic testing results or differences between one person's confirmed disease causing change to the other to, have a significant effect on treatment or screening decisions.
I completely agree.
And I agree too. So I think we've cleared up some of our questions now. I'm sure as we go a little bit further, we might get some other questions at the end of this session. So thanks for using the Q&A tool, everybody. And Julie has put a link in the chat to the Invitae test link. And without further ado, the upcoming new things in HCM. Dr. Ahmad, tell us what the future looks like. Where's the crystal ball?
Yeah, so that's what I'm planning to do here. We've heard a lot about, what the state of the art is. And so my job is to kind of look over the horizon a bit. So I'm going to tell you a little bit about what's pretty close to the horizon and just a little beyond, and then some that's actually well beyond the horizon still. I do have a disclosure relevant to this talk, which is that I do actually get research funding from Myectomy, which is now part of Bristol Myers Squibb, for my basic science lab. And I will be discussing one of the drugs that is up and coming that is going to be at one point marketed by BMS, by Bristol Myers Squibb. But I think I will be pretty even-handed about discussing it. So in terms of drug therapy, we all know, and many of you might be on these medications for symptoms and for obstruction of blood flow out of the heart. You might be on beta blockers or calcium channel blockers. A few of you might be on disopyramide. All these drugs work by kind of reducing the force of contraction of the heart, and that actually helps relieve the obstruction of blood flow out of the heart. Now, there are some other sort of emerging therapies, and one is that actually many investigators over the years have tested existing drugs to see if they might work in HCM. Often starting with animal models and moving to humans, and most of them actually haven't panned out. But there's some very recent data from a paper suggesting that one drug, valsartan, might be helpful in some patients with HCM, and I'll discuss that. I'm going to spend the bulk of my time talking about the new myosin inhibitors that you've probably heard about, mavacamten, which is being developed by Myectomy and Bristol Myers Squibb. and aficamten that's being being developed by Cytokinetics. Now I'm going to touch a little bit on gene therapy. There's a variety of different methods for gene therapy and strategies, and I'll just give you one example of something actually that we're working on in my lab. All right, so a lot of science has happened in the past basically 2 or 3 decades, and we actually now have some degree of understanding of how these genetic variants actually lead to the disease. And so this is basically the molecular motor of the heart muscle cell. And if you ever wondered, why does muscle contract? It's actually because of this. You have these little molecules sitting in the muscle cells, and you've got a thick filament and a thin filament, and they're kind of in parallel to one another. And then you've got what we call a myosin head, which is like an oar that sticks out and latches onto the thin filament and then pushes the thin filament past the thick filament. And that's actually what causes contraction to occur in the heart. And the analogy I use is that this is an oar that's dipping into water and pushing the water past the boat so that the boat can slide. Now, normally, when the heart is relaxed, that myosin head, that oar, sits in an equilibrium between 2 states. One is called the disordered relaxed state, and one is the super relaxed state where it's actually turned over on itself. And in the super relaxed state, it can't interact with the thin filament at all. But in the disordered relaxed state, it actually can latch on to the thin filament and cause contraction to occur and also impair relaxation of the heart. And so this is why what happens we don't know whether it's happening in every single mutation leading to HCM, but certainly in many mutations, what happens is that you get a switch of that equilibrium. So none of the heads, or very few of the heads, are in the super relaxed state, and most of the heads are sitting in the disordered relaxed state where they can actually interact with the thin filament. And this is why HCM hearts actually are overactive. They're overly contractile and they don't relax too well. So what has happened over the past probably decade now, since around 2012, is that a number of pharmaceutical firms have been looking at developing molecules that can actually go in and force that myosin head to go from that disordered relaxed state into the super relaxed state. So there's 2 drugs that are currently in active development. One is mavacamten and the other is aficamten. And both of these will kind of force that equilibrium so that the oar is no longer active. And so that causes the heart to be less contractile and lets it relax more easily. And so there's been a lot of work done in animal models and cell systems, and then eventually in human subjects. There've been several trials. The one that's the most definitive, what we call a phase 3 clinical trial, which is the most rigorous scientifically designed trial. What's been found in human patients with HCM is that it actually does decrease the degree of obstruction of blood flow out of the heart. So as you remember from Dr. Ashwath's talk and Dr. Panaich's talk, when this wall of the heart muscle is overly thick, it gets in the way of blood getting pushed out from the bottom of the heart out into the artery that goes out to feed the body. And so if you are able to reduce that force of contractility, then it's easier for the blood to get pushed out. And so here we have patients, in roughly 125 patients in each group. This red group got a sugar pill, placebo. This group got the mavacamten. And as time went on over 30 weeks, when the patients had echocardiograms done, you can see there's a nice drop in the obstruction. The pressure gradient went way down from about 50 down to somewhere in the teens. So that's really a remarkable effect. And after exercise, the same thing was found. So with exercise, the heart gets hypercontractile and the obstruction gets worse. But patients that were in blue here that got mavacamten, their obstruction after exercise was much less than the patients that just got the sugar pill. And so this change in obstruction also translated into improvement in symptoms. And so we divide up patients into 3 or 4 classes depending on the severity of symptoms. Class 1 means they basically have no symptoms. Class 2 is kind of mild symptoms like mild shortness of breath or chest pain on exertion. Class 3 is very significant symptoms on exertion, and class 4 is actually symptoms even at rest. So by definition, the way the study was designed, patients were either class 2 or 3 when they entered into the study. And then when they got mavacamten, you can see that this blue represents patients that dropped down into class 1, where they actually had no symptoms at all. And so by the end of the trial, 30 weeks, about half of the patients no longer had symptoms at all. And the others, they had symptoms, but fewer of them had as severe symptoms as before they started the trial. You'll notice that even the sugar pill, there was what we call a placebo effect. So some patients actually did have a reduction in symptoms even on a sugar pill. Now, what's really interesting is what's happening at the physiological level and in terms of symptoms is great, but there's also the possibility that mavacamten and similar drugs might actually change the disease process a little bit too. So these are animal studies. We study a lot of genetically engineered animals, especially mice, and these are pigs. Actually, these are little piglets born in my lab, where this is actually the very first litter of pigs that in the world that had genetically engineered mutation that causes HCM. And so these are published data from another group in mice, where they looked at 3 different mice with different mutations that lead to HCM. And the mice either got no treatment here in red, or they got treatment with mavacamten. And in all cases, they had less muscle thickening if they got mavacamten. And you can see this is like a microscopic slide of the hearts. This is an untreated mouse heart. This is a treated mouse. And you can see that this heart is less thick. Also, if you look really closely, there's some blue here on the staining on the slide. The blue represents scar, which happens in HCM. And you saw that, Dr. Ashwath showed you that on the cardiac MRI studies. And that kind of did not appear in the mice that got the mavacamten. So it looks like mavacamten might potentially be disease modifying and not just help treat symptoms. There's some human data now to suggest that this is happening. So this was a subset of patients from that initial Explorer trial that got cardiac MRIs. And I'll just show you a couple of panels here. They looked at patients' mass, heart mass, and they found that these are the treated patients here, that these treated patients had a reduction in their heart mass compared to the untreated patients. Also, though, interestingly, this is a measure, late gadolinium enhancement is a measure of scarring in the heart, and there was no difference. So even though the patients had a sort of regression in heart mass, there was no change in scar, which is, I think, not surprising, because in the animal studies, the animals got mavacamten very early in life, whereas these patients got mavacamten much later in life. And it's really hard to get rid of scar once it's there. So it's not too surprising that mavacamten is not going to be that successful in eliminating scar that's already there. So the other agent that's in development is aficamten, and this is a similar drug. It works similarly. It has a little bit different sort of pharmacokinetic profile, but it's similar. And this is a phase 2 trial. So this is an earlier trial. It's not definitive yet, but it shows that patients that got, the 2 groups of patients in blue are the ones that got aficamten, different doses. The orange here represents patients that just got the sugar pill. And again, there was a nice reduction in the pressure gradient in the outflow tract obstruction in patients that got the aficamten. And when they stopped taking the aficamten, the gradient went way back up to the same as the sugar pill patients. And also indicated here in purple are the patients that actually had a reduction in their class of symptoms. And so for the higher dose, at the end of the study, about 2/3 of the patients actually had a reduction in symptoms. So again, the obstruction correlated, the improvement in obstruction correlated with the improvement in symptoms. So those are the 2 sort of agents that are currently in development or may be approved by the FDA at some point and may become available. Let me just switch gears. I'll give you an example of an existing drug. It's called valsartan. It's in a class of medicines that's actually used mostly for high blood pressure and heart failure, but it's been shown to be helpful in some patients with HCM. At the scientific, sort of the molecular level, what's happening is that the heart muscle cells release what I call evil humors that cause heart muscle damage. And one of the evil humors is called TGF-beta, and that causes some of the muscle cells to die and for scar tissue to appear. Valsartan and similar medications actually inhibit this evil humor. And so Caroline Ho and her colleagues in Boston postulated that this might this agent might actually help patients with HCM. And so this is a complicated sort of graph, but they had a scoring system where they looked at many different forms of, or many different aspects of HCM, like wall thickness, chamber sizes, how well the heart contracted, how well it relaxed. They put it all together in scarring, they put it all together in a scoring system. And this vertical line at 0 represents no change in that score before and after valsartan. Now here, the box represents the average change in score with valsartan in all patients. And then the horizontal bar just represents sort of the range of differences in that group. And so for all patients taken together, there was an improvement in the HCM score in patients that got valsartan. And then if you break it down, it was pretty effective in both women and men. It was effective in older people and younger people. The only difference really was in the severity of HCM at the beginning of the study. So if the patient had a smaller score, that is to say they had less severe HCM, they benefited from valsartan. But if they had a higher score and more severe HCM, they did not benefit. So it looks like valsartan may be helpful, but only if it started pretty early. Again, it's a phase 2 trial. We'll need more data, but it's kind of promising. And right now, we don't really offer any medications to patients that have a genetic variant, but either no disease or mild disease. This might be an option to help prevent disease or at least slow it down in the future. And I'm going to stop with just one strategy for gene therapy. There's many different strategies that are being used. This is one example, and it's actually something that we're going to be working on in our lab in collaboration with the biotechnology firm. What we do here is use a virus, and I know everybody's scared of viruses these days, but this is a good virus. It's engineered, so it's pretty mild. It doesn't cause any major disease, but it likes going to heart muscle cells. And inside the virus, we package in a normal copy of the mutant gene. So whatever mutation that mouse in this case has that causes HCM, we just package the normal copy in there, inject it into the mouse, and it'll go to the heart muscle cells and infect the heart muscle cells. And depending on how much of the virus you give, this is the normal gene copy that goes up and up, and the abnormal gene copy goes down. So you force expression of the normal gene by injecting a normal copy through this virus. And with that, these mice actually have a drop in their heart mass. They have regression of their cardiac hypertrophy at a young age, 2 weeks, and also at an older age, 34 weeks of age. So this is one technique. There's many other ways you can actually go and sort of edit the DNA in patients potentially, but there's many different strategies that are currently being tested in sort of the laboratory setting. So what's next? So mavacamten has been submitted for FDA approval. It's being considered by the FDA. If it is approved by the FDA, there's still going to be a lot of issues with mavacamten. First, expense. We have no idea what the cost will be for sure, but it does seem that it'll be pretty expensive, at least going by other medications that have been approved for other genetic disorders of the heart. Could be thousands of dollars a month, and it's not clear that insurance would necessarily cover it. Second, it's a tricky drug. If you give too much, the heart stops working. So you have to be really careful about how much you give. It has to be done in a very controlled setting in a center of excellence that deals with this, and you have to get echocardiograms on a regular basis to make sure that the heart is working appropriately. And it's not a drug you'd get at Walmart or Walgreens or someplace. It's going to be in a specialty pharmacy. There are ongoing extension trials where the patients that were in the original trials are still being followed long-term because you don't know what the long-term effects might be of these drugs. There's also a new trial that is starting out that's going to look at patients that might actually go to alcohol septal ablation or myectomy, but instead could be randomized to this drug to see if in fact it could be an alternative to septal reduction therapy. Then, of course, we're talking a lot about obstruction of patients with obstruction of blood flow, but what about a lot of patients that have symptoms but don't have obstruction? It's not clear that mavacamten will be helpful. The data are a little bit mixed there. It's interesting, the pigs in my lab actually benefit, even if they're not obstructed, they benefit from mavacamten, but it's not clear that humans are quite the same. Aficamten is the other drug that's under development, and actually a phase 3 trial is going to be starting, or has started actually. We're going to be one of the sites for it, and a couple of our coordinators actually on the session here today, Paige and Kim, who are going to help lead this study here at Iowa. So with that, I'm going to stop. I do want to thank, first of all, the whole team. I mean, it's been a privilege to work with everyone here at Iowa. It's also been an enormous privilege to work with Lisa and her team at the HCMA. As Lisa mentioned, we've been friends for almost 2 decades. She helped me set up the program in Pittsburgh, and then she did it again when I came to Iowa, and it's been a blast. And above all, we want to thank all our patients and families. It's an enormous privilege and inspiration, really, to work with you and to take care of your health. And also inspiration for the science we do to learn more about HCM and hopefully develop these new treatments. So with that, I'm going to stop, and I think there's a few questions already.
Thank you so much. I do have to immediately address a comment that was made in the chat that was inaccurate. Alistair, you're stating I know mavacamten will get FDA approval on 4/28/22. That is not accurate. We do not know when the FDA will act. They've already pushed back the date once. There is a chance it could be pushed back again. And there is not a guarantee that the FDA will approve. Although we are cautiously optimistic that will happen, there is still a long way in the regulatory and review process. And there are a lot of very difficult questions that need to be answered. It's not typically the role of the FDA to put a lot of conditions on where specialty drugs are administered and who can provide them. And in this case, I suspect you're going to see some interesting statements from the FDA about high volume centers, about high quality imaging, about safety plans in place. So we don't know the date. We suspect it will be in April, but we thought it was going to be in January. So cautious optimism is accepted, but guarantees are out of the ballpark right now. Agreed, Ferhaan?
Yeah, absolutely. Yeah.
Okay.
We can't predict what the FDA will do.
I just want realistic expectations.
Yeah. And if it is approved too, as I mentioned, there's a lot of caveats. There's understandably a lot of enthusiasm and excitement, including my team here, but we do need to temper it a little bit.
So I have been sitting in the background watching this since 2014 and watching the development of the molecule and the changes and the science. And we are at a very exciting point to have anything that is a targeted therapy for HCM. But I've been hearing for 5 years, oh, it's coming, it's coming, it's coming. Okay, everybody slow your roll. Cautious optimism is okay, but we need to be realistic. It's not going to be the panacea for everybody, but it will probably be a good opportunity for some, as will other drugs that are coming down the pipeline. So stay tuned. We have a question. We have a few. Let's stick with MAVA for right now. Would mavacamten, okay, Eric, I'm going to rephrase your question because this is an unanswerable question in the manner in which it's asked. So you're asking about indication. Labeled indication is very different than what you're asking. Currently, mavacamten is being reviewed by the FDA for utilization in obstructive hypertrophic cardiomyopathy, and that's it. It's got to be an obstructive. So that is part one. If it gets approved, that's the indication that we believe will be on the label. But the symptoms, that has yet to be understood completely by what the label is going to say. Must you be symptomatic to get mavacamten or just obstructed? I don't know what the label is going to say, and nobody can quite predict that. Ferhaan, you want to
Yeah,
comment?
no, that's true. We just don't know what ultimately will be approved. Explorer, which is the basis, the trial that was the basis for the application, they restricted the patients that were being entered into the trial to those that had symptoms, either class 2 or class 3 symptoms, and had obstruction 50 millimeters or more, either that could be at rest or with provocation like exercise. So those were the entry criteria, and that's the trial that's being used to kind of in the application for approval. whether the FDA will just say, okay, that's the only group that's going to be eligible, or will there be wiggle room where you can have one or the other instead of both? It's unclear. So time will tell. And over time, I think we will get more experience. Definitely BMS has initiated or is going to initiate new trials in other populations, and we'll have more data. We'll have the long-term extension trials of the existing trials to see what happens long-term in these patients. And then there's other new agents like aficamten that are in the pipeline as well that have slightly different sort of kinetics in the blood, and their half-time in the blood. So we'll see. Over time, we'll get more and more experience and more understanding, and there may be more sort of nuanced indications by that point, and we'll have a better idea of who really would benefit.
You will also see coming up in the next couple of weeks from HCMA, a couple of new clinical trials that weren't discussed tonight. We are still recruiting for the Embryo study in the non-obstructed population. We will be recruiting for a company called Celtrion. They have an agent that is similar to Norpace CR, but it doesn't have some of the side effects of Norpace. So it will potentially be another option coming to market for obstructive HCM. It's important to note that their agent is currently approved and has been used for over 30 years in Japan and Korea and a few other places. So it's a known drug, but it's not approved in the United States. So we're going to do trials here, and that might be another option for people to consider when they're looking at clinical trials. Sequoia, we mentioned, is opening up, and we're going to have some announcements on that on February 23rd. Stay tuned, people. Lots of exciting stuff happening on the 23rd. So you'll have an opportunity to learn about more of these wonderful trials. Okay, people, please put the questions in the Q&A, because I'm going back and forth between the chat box and the Q&A. You're confusing me. Likely restrictions on left ventricular ejection fraction as well. There's going to be a lot of precautions put on mavacamten. Let's not forget how important a good launch is going to be if we get approval. Nobody wants the wrong people to get the drug. That will make the drug look bad. That will make the data get all screwed up. We want the right people who should get the drug based on the clinical trials that have already been done to get it first. And then we do additional trials to see who else may benefit. Exactly what was said earlier, the ejection fraction could fall quite significantly if it's the wrong patient and the wrong dose. It's got to be watched really carefully, people. I know there's a lot of excitement. I'm excited too, but we need to be cautious. So go slow. So that answers that one question. The next question is, can we speak to genetic therapy treatments that are evolving? We talked a little bit about that at the end of your talk. I know I have had conversations in the past 6 months, 7 months with 5 new firms interested in creating genetic therapies targeting different points. Some of them are going specifically after different mutations within HCM. Some of them are in concept talks at this point to figure out where they want to go. But there is no lack of interest and no lack of science to support the concept that genetic therapies are coming. So talk about unbridled enthusiasm. Wow. Like the first time I heard that this was like in the pipeline for realistic consideration in my lifetime, my head almost exploded. Like, we're really going to do this. We're going to see this happen. But when, exactly how, and patient selection, boy, do we have a lot of thinking to do.
It's going to take time. The one good thing is that these technologies are a little bit interchangeable. So some of these same technologies are being used in other disorders, not just the heart, but skeletal muscle, Duchenne and Becker muscular dystrophy, for example. And they can be repurposed in many cases for heart muscle. So we can borrow a lot from our neuromuscular colleagues and vice versa. And so there's a lot in the pipeline, many different strategies. I just gave you one example. There's many others. They can actually go in and try to repair or take out the abnormal part of the gene in the DNA in the cell So there's multiple ways to approach it, and they're all being tried at least at this point at the cell level and in animal levels. Obviously not yet, in humans, but it's it's in the pipeline.
It's exciting that it is in the pipeline, and we wait cautiously and optimistically that this will lead to some good answers. We know PGD is an amazing technology to use when trying to have a child within an HCM family and a known gene, but it's going to be amazing to see what comes next. Okay, Becky, are you still with us, dear? It's your time.
Woohoo! It's finally me.
I hung in there all night, Becky.
I did. And
thank you.
let's see if this all works. So I'm Becky. I'm the gatekeeper for this lovely program. And so I'm going to tell you how to get to see me, how you get to play with us. And did it come up on your screens?
We have it on the screen, but you're not in present mode. You got to hit that little button on the side there. There you go.
Did it come up? Because it
nope.
For me. See, I was so prepared. Okay, here we go.
There you go. But now you're on the wrong screen. You have to go to display settings. So we're not seeing your preview view. Up top. Up top. There you go. Swap.
There you go, right?
That's it.
Okay. So technology is not my fun place. So these are some of the services that we have here at the University of Iowa. We do genetic consultations with the cardiologist. We have a nurse practitioner and the 2 genetic counselors that you've talked to that can do genetic testing for us as well. We obviously have echocardiograms, cardiac MRI, and cardiac CTs. We do exercise stress testing, additional evaluations as needed with doctors that put in ICDs, electrophysiology studies, loop recorders, ablations. And we also do right and left heart catheterizations and alcohol septal ablations, which have all been discussed here already to some degree. And we also do cardiac rehab, cardiac transplant, sleep medicine. We have psychiatry to consult to, and also family planning and high-risk obstetrics. And obviously research protocols that Dr. Ahmed had just spoke to you about. So I want to talk to you about the referral process. So how we get our referrals mostly are from cardiologists and primary care physicians. Family members with patients with HCM diagnoses also refer their patients or their family members to us. And HCMA is very nice, and they send us patients as well. Once the referrals are obtained and referrals and records are obtained, we review the records, order the attesting that has not been done and that we find appropriate, and then we schedule the testing and appointments. So that's the fun that we can offer you. And this is our contact information. We have a website and also a local phone number and obviously a 1-800 number, and you fax your records to me. And then we get them into the pipeline. I don't know if I spoke too fast, but this will all be on the website. See, I was so excited to speak, I probably spoke too fast. And
I think you spoke Jersey speed, and that works fine for me.
And then we have questions. So,
let's see if we have any questions. I like your beating heart. It's very cute.
Thank you.
I steal that one. That's a good one.
We were trying to get really after I found it and put it in, one of the kids in the lab were trying to help it get bigger and smaller to show a normal to hypertrophic, but we are not that skilled is what we've decided.
Yeah, graphic animation is an art form of itself. So nicely done anyway. Okay, does anybody have any questions about accessing care? We have something in chat. Go, Becky, go. You got people cheering you on out here, Becky.
Hey, wait.
That was Howard cheering you on. So
Well, I love you all.
there you go. We always love the gatekeepers, people. Let's be real. The gatekeepers really make our lives really nice when they do their jobs well. Okay, our Facebook crew, we are going to be leaving you now. So thank you for joining us live on Facebook. I encourage you all to sign up for the February 23rd HCM Awareness Day extravaganza. So you can sign up and you can come in and out. Yes, it's going to look like it's an all-day event, but you can use the same link all day long to join us and come in for different features. So sign up so you get the Zoom link so you can see what's going on. Not all content will be streamed on Facebook. Some will, some won't. So come on, sign up, join us February 23rd. Wear red, talk hearts, tell stories about yourself to your friends and families so they know all about HCM. And please remember to remind your family members to be screened for HCM. Don't let them become an unwitting victim of HCM unnecessarily. So thank you, Facebook, and we are out. So it's just us now. Denise, raise your hand. Oh, so good raising your hand. Do you have a question, Denise?
Nope, push the button by accident.
I'm like, what? She's being formal here. She's raising her hand. Okay, I don't see any pending questions. I'm going to turn off the record button. So if you guys want to ask a question, you can populate it now, and we are going to, yes, I'm